Hello, everyone. Greetings of the day to you, whichever part of the world you are in. Welcome to the webinar on artificial intelligence in chest radiology. I am Dr. Vinita Sharan, and I will be moderating this session. I was Associate Professor of Radiology at San Beda College of Medicine, Manila, Philippines from 2006 to 2022. I am the advisor for radiology CMEs, a global association of physicians of Indian origin. GAPU's vision is improving health worldwide through enabling and empowering our physicians of Indian origin in India and abroad to reach international standards. In line with this vision, we started the radiology CMEs in November 2022. Our first webinar was on advancement in breast imaging. It was in collaboration with Indian College of Radiology and Imaging, ICRI. Our second webinar was on cardiac MRI. It was in collaboration with Global Association of Radiology Technologists of Indian Garcio. This is our third webinar in radiology. Today's session is on chest radiographs and artificial intelligence. We have today with us Dr. Nand Kumar Jairam, the new president of GAPIO, to give us the opening remarks. Dr. Jairam is currently an independent healthcare consultant and advisor Sears. He is chairman and co-founder of Shamrat. Dr. Jairam was the chairperson and CEO and Group Medical Director of Columbia Asia Hospitals in India from November 2004 to July 2021. He was advisor at Manipal Health Enterprises from July 2021 to November 2021. After completing his MBBS and MS in surgery from Bangalore Medical College, he started his career at St. John's Medical College and Hospital as a lecturer in 1980. And over the next 14 years, he rose to the position of professor and head of surgery and also member of the board of administration of SJMCH. He trained in colorectal and minimally invasive surgery at St. Mark's Hospital in 1986. He was medical director of Malya Hospital, Bangalore from 1996 to 1998. He was chairman for quality in health at CII Institute of Quality from 1999 for 2 years. He has served as chairman of NABH under Quality Council of India. He is past vice chairman. He has served as chairman of FICCI Health Services Committee. He was member of Health Insurance Forum of IRDA and FICCI. He is founder member of Nat Health. Dr. Jairam has many papers, including publications in the prestigious, including one in the prestigious British Journal of Surgery. He also had many presentations. He has received several awards, including Personality of the Year Award of FICCI and Lifetime Achievement Award by Alert. I now invite Dr. Nand Kumar Jairam to give us the opening remarks.
Thank you, Vinita. I'm very pleased to be here this evening. This is the first webinar that is happening after I took over as president, and certainly will not be the last. GAPIO is known for its learning and development initiatives, amongst other things. And I must laud the efforts that Anupam Sibal put in during the time of COVID, which kick-started the webinar series and which is continuing with full gusto even now. I thank all of you for organizing this session at very short notice, and I understand the importance and value of this. I'm sure all of who joined today would really enjoy the session and benefit from it. I also urge those of you who are in the audience and not members of GAPIO to kindly become members of this illustrious association. You will understand the value of synergy, of camaraderie, and of joining together of a group of people who are of Indian origin and taking care of humans and providing them with medical care across the globe. There is a lot that can be learned, a lot that can be synergized, and I would look forward to ensuring that we do this year and in the following years as well. With these opening remarks, I hand it back to Vinita. Thank you indeed for that very, very elaborate introduction. And I leave it to you to take it over and conduct the session.
Thank you very much, Dr. Nand Kumar Jairam, sir, for your inspirational words. I hope we will continue with all the webinars and continue spreading the knowledge to everyone. So artificial intelligence is one of the most rapidly expanding technology being applied everywhere today. Healthcare is not an exception. Radiologists are applying artificial intelligence to enhance their diagnostic prowess. In our first session, we had seen how artificial intelligence was being applied for early detection of breast cancer. Today, we are going to hear from Dr. Amit Karat on artificial intelligence being applied to chest radiographs. Chest radiographs are the first line of imaging for various diseases. So we will find out today how well AI improves detection of abnormalities. For introducing our speaker today, we have our chairperson, Dr. Nidhi Goyal. Dr. Nidhi Goyal is a senior radiology consultant at Indraprasth Apollo Hospitals, Delhi. Dr. Nidhi is thesis guide and assessor of National Board of Examination. She is faculty with ARI FRCR Joint Program for FRCR examination in Hyderabad. She is the course coordinator for DEL-RAD Radiology, a resident review course. Dr. Nidhi is editor of Journal of Orthopedics and reviewer of Indian Journal of Radiology. Dr. Nidhi has expertise in cardiovascular imaging with special interest in cardiac MRI, musculoskeletal radiology, and neuroradiology. She has approximately 10 chapters in various books, more than 20 publications in various national and international journals, and more than 30 presentations. Dr. Nidhi has been awarded with IRIA President Appreciation Award. I now invite Dr. Nidhi Goyal to introduce our speaker, Dr. Amit Karat.
Hi, good evening, everyone. I hope is it audible, Dr. Vinita?
Yes, you are audible.
Okay. Good evening, Dr. Jairam. It was nice for you to take as a chairperson for this KPO. Dr. Amit, it is a privilege to introduce you today for this evening, and there will be lots to learn about the AI in the chest radiology, because this is the first thing that's gonna change the face of the radiology along with the CT head. That are the two things which are the initial introductions in the artificial intelligence in today's world. And we are gonna go further ahead with the AI in further complicated things. So Dr. Amit is MBBS, DMRD, DNB, and PhD. He is currently a co-founder and CEO of DTEP Medical Imaging. He is a proud achiever and I will say proud achiever of the most prestigious orations of IRIA. I'm really surprised and really impressed with your orations. You have Suren Kothari Memorial Oration awarded by Indian Radiology and Imaging Association in August 20. You're also awarded with KM Rai Memorial Oration in 2018 at Asian Oceanic Congress of Radiology. You also have Ashok Mukherjee Oration Award recipient in 2014-15. You are recipient of the Travel Fellowship of Indian Radiology Imaging Association and International Skeletal Society and presentation of PhD research topic. This is really, really a very, very good achievement. Having 3 auditions in your name is really something that we all will be looking forward to achieve in our future achievements. Your area of interest are mainly artificial intelligence. You were previously the professor of radiology with Dr. D.Y. Patil Medical College and University in Pune. You are certified Massachusetts Institute of Technology, Sloan School of Management in Artificial Intelligence, Implications of Business Strategy. Artificial Intelligence Committee of Indian Radiology and Imaging Association, you joint secretary with the Musculoskeletal Society of India. But Dr. Amit, I'm really sorry, I'm a little confused about this. You have done your certification from Institute of Technology of the Solon School of Management, right?
Correct.
That's a very good achievement. You're a reviewer with the British Journal of Radiology, Indian Journal of Radiology and Imaging, and Indian Journal of Musculoskeletal Radiology. It's really a privilege to introduce you, and I hope we will learn a lot from you today in AI, in the chest radiology in today's world. Welcome for this evening session.
Thank you. Thanks a lot, Dr. Nidhi, for the nice words and introduction. Pleasure to be here. So, is it okay if I start and share my screen?
Yes, please start.
Great. I think I've divided my talk into halves. So before I start my talk, first of all, again, thanks Dr. Jairam, the entire team. Thanks Dr. Vinita, Mr. Anto, Dr. Nidhi, and all the team members. I think Jitendra, Dr. Anupam for inviting me here. It's a pleasure to be here and discuss about how AI is transforming radiology. And I think since we have people attending from various parts of the globe, also this will be streamed later. I think the top, what I've done is divided into two aspects. So one aspect is I'm going to cover is the basic chest X-ray reporting process. And then the second thing which I'm going to cover is about the AI. So that's how I'm decided to kind of break my talk into two so that it becomes easy to understand AI. So let's start with the first half of the topic, which is basically about the anatomy of a radiograph, specifically the chest X-rays. Right. Sorry, I think there is some background coming.
I will request everyone to please mute themselves.
Right, and yeah, so let's start with the anatomy of the radiograph. So the first part of the topic here, basically what we will do is we will look at what are the indications of the chest X-ray, where all we do chest X-rays, and so on and so forth. So let's start with the standard view, that is the posterior anterior chest X-ray view, and the most common reasons I will try to list on the left hand side. Primarily, the role of chest X-ray is for lung disease assessment, and this includes diseases of the lungs or the pleura as well. It is also primarily a very important tool for cardiac assessment. It's also a very important tool for tuberculosis detection, and that's something which I would like to talk in detail later on in the topic. Foreign body assessment, that could be various wires and tubes which are placed on the within the chest or on it during various procedures, and there are close to 16 to 20 of them, and that could be encountered on the chest X-ray frequently, and there are many more which could be encountered little less frequently. Treatment and progress monitoring, basically for any particular chronic lung disease or any other disease with lung complications. To manage the disease, to see the treatment progression, this is one of the very important imaging modalities. And now more and more, the lung health issues are coming up, and we are talking about lung health in a very broad way. So this tool has a potential to actually be the first and the basic tool, as it's going to get transformed much more from here as it becomes a tool for lung health analysis. We all know that it is one of the most cost-effective investigations ever in the space of medical imaging. The X-ray chest still is the most cost-effective, and in that, what more we can derive from about lung health using new age technology is something which is under research, and also for pre-operative assessment. So that's all in terms of what are the different ways and means in which we use chest X-ray. So this is a standard chest X-ray PA view. And in this view, I think one of the most important things we need to understand as to how do we differentiate a PA from an AP view. So the first part of my lecture will try to cover all these important aspects. So if you see the clavicles in this X-ray, the clavicles are kind of covering the lung apices, and that's pretty standard in the PA view. And if you look at the scapulae, they are fairly widely placed or away from the chest beat. So that is again an important thing that we look at. There are other things as well, like the heart may be enlarged on a AP view, but that's something that we will see when I'm looking at the AP radiograph. In the AP X-ray, which is anterior-posterior view, which is less common in a OPD setting, but more common in an IPD setting, you will see that the clavicles are kind of away from the lung fields, and you may see that the scapulae may come within the lung field. Also, in this, the heart may be, in some cases, abnormally magnified as well. So that's why in most of the cases on AP view, we do not take cardiac dimensions because it may be on the higher side. These X-rays are done in bedridden patients, specifically in the ICU settings. And if you see, many of these X-rays will typically show all these various wires and tubes, because most of these patients will have chest leads or other kind of monitoring devices added to them. And you could see them overlying the chest fields. So that's how basically we look at both the views. And as I said, on the AP, we try not to comment on cardiac cells unless you can very obviously see that it is grossly enlarged. Coming to another important view, and that's this view is done specifically when we are looking at some kind of problems on a frontal radiograph of the chest. And when I say frontal radiograph of the chest, I typically mean it could be AP or PA view. Then we go ahead and we start using the lateral view. The reason why we take a lateral view is to see where exactly on the within the chest this particular pathology is located. So on lateral, I would like to showcase a few landmarks, which is important for us. This is the cardiac outline, what you are seeing here, which is basically consisting from posteriorly by the left atrium and left ventricles. We also see the diaphragmatic outlines, which are crisscrossing like this. So that's both these are the diaphragms. You can also see the left diaphragm here, which is stopping short of the heart because both of them have same densities. One important aspect is the lucencies of the vertebral bodies. They become more and more marked as you go posteriorly and inferiorly. The reason is because this happens because of the increased translucency in the posterior costophrenic recesses, because the lungs are on either side of the spine, making it very easy to visualize. So it's very good to see the spine as well. Also, you can see these overlap created by the scapula. So that's the scapular region. You also see the hands, and that creates this added density. So there is no pathology here, but the added density has been created by the soft tissues of both the shoulders. And then the lung apices in this area, again adding to the complexity, because here there are clavicles, there is a humerus, and both the clavicles and other soft tissues which are creating this apparent increase in opacity. So the idea is to look beyond this, look beyond these opacities, understanding that these are normally present, and then come to a diagnosis. We also see the hilar region, and we see the both the end-on branches of the tracheobronchial tree as it comes towards the hilum and the carina. You also see this lucency, which basically is the tracheal lucency, and behind that will be the esophageal lucency. So that's how we look at the lateral X-ray. On a lateral X-ray, basically, on the lateral X-ray is very important for us to also see other findings as well. That is the spaces, and it's important to know that there is this retrosternal space. This is a very potentially important space. And if there are any soft tissues here, this space is going to get effaced. So with this, probably we could see the other views. Oblique views are done when we have challenges in the ribs and we want to look at rib fractures. We all see the anterior and the posterior ends of the rib very well. So if I go here, we can see that the anterior and the posterior ends of the ribs are pretty well visualized. But if you see the angles of the rib, they are not very well visualized, specifically in casualty patients, road traffic accident patients. And that's where, if you want to see that area in detail, we basically take the oblique views where you can see these angles much more better. They open up and you can count the ribs as well as the rib fractures at this areas very well. So that's why we basically take oblique views. Moving to the further anatomy of the lung of the frontal radiograph, and that's where I think it's most important for us to kind of spend a little bit more time. On a frontal X-ray, we can see that on ideal chest X-ray, you can see that the most important is the marker. Markers, they come in various sizes. This is a very tiny marker, but it's an important thing to know the site, because on that basis, everything, your diagnosis is different. You are not the one who are going to do the radiograph, so you are also dependent on a lot of things going right. And many times we see that X-rays come flipped, and just a simple error, this simple thing can create some errors. And because everything is digital, there are very high chances of errors coming up. So you can see that the clavicles overlying the chest field, and this is a very important thing because many times subtle infections, tuberculosis, and fibrosis and scarring in the upper zones can be easily missed, and that's one important thing. We also see that this is the tracheal lucency, and you can see that as it goes here, it breaks down into the right and the left bronchus, and that forms the carina, and it also creates a stripe on the right hand side, and we keep a very close look at this stripe because if it is widened it may indicate that could be lymph node enlargement. We also look at the hilum primarily by the pulmonary arteries on both sides, and we have to look at this also contains the tracheobronchial tree, the bronchial tree and its sub branches or the smaller branches, and we have to look very carefully at this area because we do not want to miss any lymph node enlargement. We also look very carefully at the costophrenic recesses for any site or any kind of chances of pleural effusion or pleural thickening. These recesses are typically quite deep, and in they can be much more deeper than this. And that's a very important thing because very subtle pleural effusions may come up in this space after they fill up the posterior costophrenic recess. So because the posterior costophrenic recess is deeper than the anterior recess, the fluid will go here and then it starts showing up even in the lateral recesses. So you will not do a lateral always, but you always do a PA. So you have to look very carefully. Sometimes the fluid will be so thin, it will start kind of migrating in the pleural space like this, and it can create a effusion, which is called laminar effusion. So you have to also keep a watch whether it is artifactual or it is really laminar effusion. And that's where we do ultrasound when we have some doubts and we don't know why that fluid is there. As you see, the vascular markings, they are there in the 2/3, and in the last 1/3 you don't see much of them, and because they start pruning in terms of its natural size, it starts reducing, and because of that you see that mostly the lung looks more lucent as we go towards the periphery. So that's a very quick and a basic overview of the anatomy. But also at the same time we need to know about the hidden areas, and one of the hidden areas I actually described when I was talking of the costophrenic angles. This is one of the very important hidden areas because fluid accumulating here may not be very easily seen, or any pathology or a lung nodule sitting in the posterior costophrenic will not be seen. You see the diaphragmatic outlines, but the posterior costophrenic recess is so deep it will be somewhere here. Similarly on this side, so you have to start looking for any added opacities, which may not be very easily seen because of the thick, large liver, and then the stomach bubble may make it very difficult to see. So this is what we call as a hidden area 1 and 2. That's a very important thing to know because we have to look very carefully. And that's why reading X-ray is more of an art than anything else. The second hidden area is the retrocardiac space. So this space is a hidden area because if any pathology is there behind the heart in the lungs, it is going to overlay the heart. It will create a double density kind of a shadow. And then we have to kind of look through the heart to understand there is a opacity lying there. So this becomes a hidden area. Both hilum also become hidden because if there are smaller lymph nodes, they can be completely overlapped by the hilar vasculature, pulmonary arteries, and we may not be able to see beyond them. So initially, they both may look the same water density, and we may completely miss them, and we need to probably do some proper kind of keep a very high index of suspicion that we don't want to miss them. And I also described this area lung apices where we can have these lymph nodes, these lung opacities, which are tuberculosis or something like fibrosis and scarring, which can be cavitatory lesions, which can be easily missed because clavicles can create that opacity. And many times this area, the sternum, where the sternum and as well as the first rib, there's a junction. We can see that there's a cartilage there, and the cartilage also creates the appearance of a lesion. And again, anything beyond that can result in missing of certain pathologies. This is also known as a student's tumor because first year radiology residents look at this important junction between the first rib and the sternum and kind of think that it's pathological. Coming to important quality issues, quality issues can be very subtle and we have to be careful. Like as you can see, this is an artifact. It could be on the cassette on which the scan was done. The second important thing is the exposure factors. Ideally, the first 4 intervertebral disc spaces should be very clearly seen. If you're not able to see all of them very clearly, probably it's underexposed. And if you are able to see all of them very clearly, as if you're looking at a spine through the chest, then it is overexposed. And the ideal X-ray is not either of them, is the middle path. That is what we call as a balanced X-ray or the appropriate X-ray. Pediatric X-rays, I would like to take a minute to talk about them, because that's very important for us to know about them. Because as taught to us, and we all know that pediatric X-rays, the kids are not miniature adults. And when we see or take an X-ray on a regular cassette, you see more than the X-ray chest. You see the abdomen and even the pelvis. So one is important is about protecting the child in terms of any exposure to radiation, because they are very vulnerable anyway. And the second important aspect is to see that the lungs, whatever area we are looking at, is covered well, and there is less and less of motion blur. As you can see in this case, there is a lot of motion blur. The child has moved, even the rib cage, you can see that there is a lot of blur. This limits our ability to visualize, but many times we have to be very judicious in deciding whether we need to go ahead and report this, or we are likely to miss certain pathologies in such conditions. And that's why pediatric X-rays are extremely important. Again, about motion blur, it may be sometimes visible and very clearly seen. Sometimes it will be some like this, where it is, you can clearly see the blurred lines on the right side of the image. And in ICU patients, we all know that their breathing is completely kind of disturbed, and they may be hyperventilating. They may be under significant stress, and you may not get the best image always. So you have to do with what's available and try to give your best diagnosis. And again, you may have to deal with a lot of tubes, like as you can see here, and kind of try to find out why these tubes are here, or look whether these tubes are appropriately placed, because we all know that there could be iatrogenic issues in the ICU because patients are semi-comatose or comatose, and they are not able to uh, kind of reply back to any commands. So the positioning of the tube, it becomes extremely critical to know that they are aptly placed in the right location. The films can also be mid or end expiratory. Like this is the end expiratory tube film, because you can see the first rib, the second rib, and then we fall short at the third rib itself. You are able to see the diaphragm. Ideally, the first anterior ends of the first 6 ribs, if they are seen, or the posterior ends of the first 10 ribs, if they are seen, we have a good, well inspiratory film. Because in such a X-ray, you can imagine your half the lung is completely um, non-visualized, or is difficult to visualize, and you are probably going to predict many things rather than actually view them. So we need to know that in such situations, you are limited by what you are seeing. I think that covers some anatomy. Let's go within the X-rays and try to see some pathologies. And as we know, chest X-ray itself could be a day-long topic, and I'm going to just give my best to try to, in the next 10 minutes, cover some key aspects. So I covered pediatric X-rays. So these are adult X-rays. Sorry about the title. I think it just came in here. Just wanted to talk about these X-rays and discuss about them. As you can see in this X-ray, there is this lesion in the right lung, and there's also a lesion in the left lung. And you also see that there could be nodular lesion here. There's a fibrotic scarring here, and there is some kind of fibrosis here. So basically, we're looking at some kind of scarring, and this could be because of some previous infection, and it does not look to be active. This probably could be some tubercular scar or some other disease as well. We need to investigate that. While this is to show cardiac abnormalities, where we can see that the heart is obviously enlarged, and even as residents or even third MBBS students, we are able to know that. My idea is to go beyond that and see why it is enlarged, and try to see if we are able to give some reasons behind it. So we have to always look at other important signs. We know that the patient is old. We see that there is aging. We see that the aortic knuckle calcification is there. We also see there is some unfolding of the aorta. We also see that there is significant enlargement, which could be of the left ventricular type. And the heart is maintaining its 2/3 by 1/3 ratio, with the right side and the left side being, we can see that the heart is generally enlarging in that particular size. So we know that there is most likely some kind of enlargement, which could be left ventricular type as well, though we are not very well able to see the apex of the heart. But this probably could be hypertensive. And I think that kind of conclusions become pretty important when you're looking at pediatric X-rays. So the way we have been taught is that we could either go from outside in, looking at the rib cage, the pleural spaces, the lungs, and the heart, or we could jump the opposite side, that we can start from the heart, look at the hila, look at the lungs, pleural space, and the ribs. Anyway, it basically depends upon the radiologists and the kind of mentor they have chosen, and then they want to go, and either way is correct. And it basically is ensuring that you have a checklist in front of you. You have covered the entire heart. As in this case, where you can see that the challenges as well as there are opportunities to make a diagnosis. You see it's a mid expiratory to an end expiratory film, but you can clearly see that overlying the heart there are opacities here, and there is also subsegmental base atelectasis. So we could still come to some conclusion. But many times radiologists are only going to be limited to giving the opacities or the findings. They may not be able to go beyond unless and until we have some kind of clinical information available to them. Otherwise, it will be very difficult to tell why these opacities are there. There are so many different reasons under the sun why this lung opacities can arise. It could be right from pneumonias, and as we know, even COVID can look like this today. And we also know there could be any other fluid overload conditions can also create some kind of similar appearance. So we need to understand whether the patient is in failure, or there is some fluid overloads and the patient has been admitted in the ICU. Was it patient has presented with these patches in this particular format, or and how long the symptoms have been there. So I will cannot reiterate the importance of clinical history while X-ray chest reporting. In fact, it becomes one of the most critical elements, without which I think radiologists will be completely in the blind in terms of understanding why a particular patient has a particular type of patch or feature. This is again to show pleural pathologies also. Like in this case, you can see that there is pleural effusion, which is tracking along the chest wall. And the pleural effusion can have various type of appearance. It could have a concave inner margin. It could have a convex inner margin. And depending upon that, you need to take a call and label this effusion, or in terms of suspicion, whether it is loculated complex effusion or a simple effusion. Simple effusions typically have a concave margin. Many times along with the effusion, you can also see haziness in the lung. And then what it becomes is a pneumonic effusion. Again, there is a pneumonia as well as there is effusion. It can happen because of pneumonia itself, or primarily it's a effusion which could have secondary resulted in some lower lung collapse. So that is what we call as atelectasis, and there could be partial atelectasis. The mediastinum shift, which is the shift of the trachea and the mediastinal structures like the heart to one side, can happen if this fluid completely overtakes the left lung and fills up the lung, and then it kind of displaces everything on the right hand side. And that's why it is very important to know, if the fluid is complete but there is no shift, then that means that the left side underlying lung has collapsed. If the fluid is completely filled up the left lung and the mediastinum has shifted, that means the underlying lung has not collapsed completely. And that's how we basically come to some judgments or diagnosis. You can see this other patient which has some kind of a tube on the right side. And this tube is basically probably to drain some fluid in the pleural space. You can also see there is air. So we don't know whether it's a pneumothorax or the air has been introduced because of the tube to drain the pleural fluid, and what was this patient from the casualty. You also see tubes like the endotracheal tube can also be placed, and you can also see these huge large patches in the lungs, which could be very difficult to determine the cause until we know what is the clinical history. In this case, it could also indicate ARDS. We have seen a number of such cases during the COVID period where patients progressed towards ARDS, and that's why serial X-rays were extremely critical to see whether the patients were resolving or not. If any modality was used significantly in this COVID period, it was a chest X-ray, and it really made a huge difference for patient management, specifically if the patient were in the ICU. I think the other X-ray also has similar findings, so probably I will not spend time on that, but would like to move to some more X-rays to show other findings. So many times we have these chest leads which can create some kind of nodule or some kind of picture like this. We need to look carefully at the location of the endotracheal ETT, because that's the carina. It should not be crossing into any of the right or the left bronchus or at the level of the carina. If it's there, we need to kind of move it up. In this case, it is aptly placed, and that's why it's extremely important to take a proper X-ray so that we are able to see that. Also, probably there could be some rib fractures here. So the patient probably was a it was accident injury. Again, tuberculosis can have multiple varied types of presentation. We have these typically called areas of breakdown. And when we see them, then I think that's the only time when we are very sure that this is tuberculosis, because we see these lucencies amongst these scattered areas of lung opacities, and that probably indicates there is air bronchopneumonia. Young patients with tuberculosis, we always have to suspect white plague, what we call as HIV, and we need to be very careful that we are able to kind of correlate things and see if there is any immune suppressions. But we also see, because of usage of any anti-malignancy drugs or immunosuppressants added to the anti-malignancy drugs, we could have these issues. Important thing about lung nodules, previously I showed a chest lead, but now I'm showing a lung nodule, is to see whether it's calcified or not. And if it's not calcified, it is a soft nodule, then we need to kind of figure out whether it is a lung nodule which is incidental, whether it's because of a previous scar and previous chest infection and it is stable, or it is something which is much more kind of dangerous in terms of is it malignant. And you could actually make that out very clearly by looking at the lung nodule's character. And in this case, when I see it as a calcified nodule, I am not really worried, because I believe that it's something old and it is something like a scar which is remaining, which has created this nodule. So I need not worry. But a nodule which is larger than this, around the centimeter, which is rounded, and if they are multiple, then I'm really worried, because that could be metastasis. It could be metastasis from various type of lesions, like even osteosarcomas can give lung metastasis, breast cancers can give lung metastasis, any GI cancers can also give rise to lung metastasis, and every lung metastasis have a different appearance. The metastasis from osteosarcomas are very dangerous in terms like they can cause spontaneous pneumothorax, and they are very large in size, and that's when we call them as cannonball like metastasis. Coming to some more important features is looking at the aorta and the unfolding. Sometimes you may not know whether it's the unfolded aorta. Sometimes you never know, because it is just because of rotation that the clavicle on the right side, if you see it's not equidistant to the left, that means it could be significant rotation, or we don't know whether there is an underlying aneurysm of the arch. So when you make such comments, or as radiologists, we have to be very careful that we look at rotation. In this case, I feel that there is element of rotation. There's also element of unfolding. Unlikely that there is an aneurysm beyond that. So that's why we have to make these judgment calls, because that's the first time we are encountering that patient. Coming to other lesions like lung mass, and the lung masses can present in various different forms. And it's very important to characterize them well, define them well as to how these lesions look like. So as in this case, you can see it's a well-defined rounded mass in the left lung base. And in this case also, we have a well-defined mass in the right lung in the mid zone. So the zones are defined on the basis of the ribs. So if you see the first rib and the second rib, they will constitute the upper zone. From the second rib to the fourth rib will the mid, and anything beyond the fourth to the sixth is the lower zone. So this lesion is in the mid zone. This lesion is in the lower zone. This lesion is also in the mid zone. But all of them have different character. If you see the margins of this lesion are smooth, this lesion also has smooth margins, but this lesion has lobulated margins. All this are basically looking at characterizing malignant lesions, but at the same time, we need to describe them well. Every sign is important, whether it has smooth margins, whether it has lobulated margins, it has evidence of calcification, cavitation, air fluid levels, presence of any satellite nodules around it, contralateral lung involvement, like in this case, hilar lymph nodes, if any, and metastatic lesions, like in the bones. There are many times X-rays you'll encounter where you'll see all these findings on the same X-ray. You'll see that there is a primary lung mass with lymph node, as hilar metastasis, ipsilateral contralateral lung metastasis, as well as bony metastasis. And the diagnosis becomes very crystal clear. Yet there are times, and when we do musculoskeletal scans, we are many times confused whether the primary is in the bone or the primary is in the lungs. And as radiologists, we come across this in our various crop interdisciplinary meetings, where we fail to come to diagnosis whether it is a lung carcinoma which has done metastasis to the bones, or vice versa, it is something from bones which has come to the lungs. And that can be really complicated, and until you don't do a biopsy, you will not come to a conclusion. Coming to pleural lesions, that's a pneumothorax. you can see the lung has completely collapsed and moved medially. And what you see is a large area of lucency devoid of any vascular markings. And that basically it's also going here and then comes here back. And that's a very classical pneumothorax. Even in this case, you can see this thin margin of the collapsed lung. And beyond that is pneumothorax. Pneumothorax can be very easily missed. You need to be very careful, not missing it. And again, it could be quite common in the ICU settings because of hyperbaric and because of ventilators and so on and so forth. But we need to be careful that not to miss it. It could be easily missed if it's small. Bone lesions, as I said, we need to take oblique views, but yet we'll be able to see rib fractures. Like as you can see a lot of crowding here and multiple rib fractures. This could be old. Even these are look to be like old rib fractures. Even here, there are like multiple rib fractures which are existing, and we need to be careful about that. I think that I took around 20 minutes around to cover this. And let me now move to the second aspect. Like we saw so many pathologies, we see so many different diagnoses, and a very rapid walkthrough how this field is getting advanced with new age technology. And that's where I come to the topic of advances in chest X-ray analysis using AI. And why this topic has been of interest to governments and at large, and almost every nation looking at seeing how chest X-ray AI could be something that could be taken into mainstream. And just to bring in some statistics, and the statistics are from WHO, where estimated that 2/3 of the world population lacks access to basic radiology services, including X-rays. That's quite a large number, considering we are more than 7 billion. 2/3 of this will not have access to X-rays. And even in countries where access to medical imaging is more widely available, access to chest X-rays will still be limited for certain populations. And the cost, it could be distance, it could be cost, lack of awareness, and about the importance of screening. And the waiting time for report, I think every geography, we have a global audience here, so you may be better having idea in terms of what's the average waiting time to get a report for chest X-ray. And in many cases, it's not reported because we don't have that many radiologists. And I think CT, MR, ultrasound, Doppler, and procedures take up most of the time of radiologists. At the same time, when we look at other important disease conditions that the chest X-ray can analyze, is basically tuberculosis. And we see that there are around 1.4 million deaths attributed to TB in 2019. And we all know COVID also played a major impact here, resulting in less number of screening during this particular period, because all the vans which were working for TB screening had to kind of shut down or had to run low because the kind of pressure on the infrastructure was significantly high. So here we come to some tools which actually do what radiologists have been doing for years. It is now trying to use the similar cognition of radiologists to do analysis. And we all at Deep Tech also create these tools. And this is just to showcase an example where the chest X-ray, which shows evidence of some lung infection, could be TB, is actually getting detected using AI, where what you are now seeing here in a colored shadow is a AI generated heat map showing these are the areas where there's abnormality. And this is a same X-ray which showing the outline view. So radiologists can now get these X-rays back into their packs with the AI output, or healthcare workers who are doing healthcare screening at the community can get the same output onto the X-ray machines, and then they can do some important decisions. I'll talk about them. Also, along with that, you get a probability score that there is likely to be tuberculosis, fibrosis. It also says that please review for pneumothorax. And the reason is because you can see there is an area which is devoid of vascular marking. So it's also giving that indication. And it also showcases that there is pleural thickening. And if you ask me where exactly it is, so if you look at the left CP angle, there is thickening. So, and the probability score is the AI's confidence in saying that this particular pathology is there or not. And as you can see, this is how it does. So the tool, what we have created is called Genki, because Genki is actually a Japanese word for healthy. And let me talk about this, how it works. As we are seeing democratization of these AI tools actually making every machine intelligent, whether MR, whether it's a CT, even ultrasound, you have seen that. Now it's happening on X-ray machines, where AI tools are directly getting embedded within the CPU within the X-ray machine. So on the display monitor itself, you'll be seeing AI output. The moment the X-ray chest is done, you're going to see output like this, and you're going to see the pathologies which have been seen on the X-rays on this right side. So as of now, we have integrated this with Shimadzu X-ray machines. And how does it help for pathology detection? So the healthcare worker who has taken the X-ray at the peripheral health center, maybe it is in a village where the ambulance or the van has gone to take an X-ray, or maybe it could be an ICU, or maybe it's in the OPD. We'll see a display which shows that this is likely to be TB suspect. It could be likely to be a potential COVID pneumonia suspect. There could be other pathologies, and that's where we come to the important issue of lung health. That means it could be cardiomegaly, lung nodule, could be a lung mass or something like that, or the X-ray is normal. And this is a very important thing, because based on this, a lot of decisions are going to happen. One is, if the patient is tuberculosis suspect or a pneumonia suspect, the patient will be taken in for a sputum sample collection. And that's how basically it is potentiating early TB detection and elimination. More of it later, but just to say that such a solution can diagnose or do instant triaging in less than 1 minute, does not require access to internet. Everything happens offline using AI. And close to 20 different pathologies, which I just described a few moments ago, can be detected using AI. Multiple X-ray machines can be connected to one laptop on which this solution can be displayed, and the same laptop connects to the X-ray machine using the port and the IP address. So it's a wireless connection or it's a Wi-Fi connection. Coming to diseases, every disease now gets an AI model. For example, to detect normal and abnormal will become an AI model. Tuberculosis becomes an AI model. Pneumonia becomes an AI model, and so on and so forth. You can see that the list is there, where you can have different AI models for different pathologies. And they can be now deployed onto a laptop based on the laptop's capability. And we can have 4 pathologies or 9 pathologies or 10 pathologies or larger set of pathologies based on what is the requirement. Is it community health screening or it is something else? So how does it work? One of the biggest challenges what the government have seen for TB elimination was that patients don't come to hospital. They are reluctant. They are daily wage earners, and patients are shy to come. So once any patient comes to the hospital and they find a positive study, they actually have to go and investigate everyone in the home, and they believe that there could be a pocket there, and there will be others who are neighbors residing next to the patient may also have high chances of tuberculosis, which is basically undetected at the moment. So it's a suspected patient. So mobile vans actually are now designed to go there, or backpack X-rays basically are taken, and they basically decide to go to a particular area. So there, patient registration happens, which are basically contacts, which are their investigation happens, and then X-ray is done. And after the X-ray is done, the AI results are available. And based on that, immediately in the same setting, a sputum sample will be collected for TB. During COVID, there was a swab collection for pneumonia as well, because there was, we are seeing that at the peak of COVID, more than 15% cases were actually showing evidence of pneumonia. And that was something which was found in the peak of COVID pandemic, even where some vans were working. And in that particular situation, the sputum is collected. Now, what has happened is 2 interventions have happened in one go. If the X-ray previously, what used to happen is very important to understand. Once the X-ray was done, it was taken offline to a radiologist, or it was beamed to a radiologist through a PACS. The report was collected and taken back by the time the patient used to go, and being a daily wage earner, difficult to track them. Now, when the patient has been lost in this particular period, he is likely to infect more other patients. Now, with this intervention, 2 investigations have got combined. Even this system connects to the cloud system, which is what you call as a hub system, where radiologists can now audit the AI output. So it's not just purely AI. The radiologists will will look at the AI output, they'll audit it, and this output is also available as a SMS report or an email report back, or a WhatsApp report back to the organization, that is the government, as well as to the patient. And plus, the data is now maintained in a control room where officers can look at which vans are active, which zone they have been working, how many patients have been scanned, and so on and so forth. Also, there is potential that it can be connected to national dashboards. Like in India, there is a NICSHE. So something like that, it can be connected to national dashboards. So what happens, every X-ray taken at the grassroots actually reflects in the national dashboard. And that's the value that a digitized system can bring into your workflow. So we have been running this in Chennai for last 3 years now. Totally, we must have screened around more than 300,000 patients, but in Chennai, we have 7 vans where it has been used. And these are the accuracies of the system, where it's around 0.92. That's what WHO recommendation, because that's where for even between radiologists and radiology variations, we have accuracy of around more than 90% to 92%. When we look at, these are the vans, that's where the X-ray happens. And this is how the output is seen onto the screen. And then the AI output is seen on a laptop. And then the decision for sputum collection is done. How has this aided the government? This has aided because you can see that the impact has been, before using AI, only 20 patients for TB were getting detected. After using AI, around 500 patients per 100,000 are getting detected. You can see that there is more than 25x increase in yield. This also also indicates that all patients are now not subjected to gene expert or TrueNAT. Only those patients which are positive will be suspected. So it also brings down the cost of tuberculosis screening. As a result of which, there's a lot of discussions, and WHO has already mandated its use for TB screening programs. In fact, on 24th March is a big event or World TB Day for this particular activity. We've been running this across Asia Pacific, right up to Mongolia, with support from various agencies like Azure, Microsoft Azure platform, and Entity Data, and also Dell. And we have also deployed this hub solution in Singapore with the Singapore Public Sector Hospital. It is under the process of deployment, where it becomes the similar platform for chest X-rays at a national level. So not only one AI algorithms, multiple AI algorithms can now be deployed, not only for X-ray chest, today for X-ray chest, but in the future for other body parts. So it becomes a part of healthcare screening. So chest X-ray is one healthcare, liver health, breast health because to early cancer detection, prostate, and these are other areas, even brain for that matter, for brain atrophy and quantification. So I think quantification is going to make radiology more objective, and as a result of this is going to come in everything. Second is to speed up the process of diagnosis, to reduce the patient waiting time, and also to do easy progress monitoring. A similar exercise we have done in Philippines. Coming to an important aspect about accuracy. And when we talk about AI models, always about accuracy, and hence a lot of research goes into actually understanding, are these AI models really accurate, or really do they create the impact they need to create on ground? So when we talk about infections like tuberculosis, it's Stop TB Partnership, FIT, which is based out of Vietnam, and other bodies, they do 6 monthly audits. And there's body like FIND as well, which does audit. And they kind of do a audit, and the results get published into scientific research as well, or can be independent audit. So this is one such audit where the AI output has been kind of reviewed with field readers, radiologists with around 5 to 7 years experience, and expert readers, radiologists with 25 years of experience. The data set comes from different geographies all across the globe. So it's not from one particular region. So that means the data has been collected from various geographies, and it is not only matched with radiologists, but also with TrueNAT and other results, microbiology, TrueNAT, or gene expert, whatever is consistent and given the tuberculosis confirmation. And then the AI models are compared. And it's not for one company. They'll do audit of all the AI companies, and they will give audit report as a transparent report to every company, and it is on the global website. So once this happens, you can see these, and you can clearly see that the AI clearly outperforms expert readers, the field readers, and matches expert reader. This is extremely important to know, because at the same time, I also want to give a word of caution. This is when we are looking at point pathologies, when we are only looking at one disease. So if a tuberculosis model can detect only tuberculosis, it will not detect pneumonia. That's a different AI model. Pleural effusion will be a different AI model. Lung nodule, lung mass will be different AI. Hence, we have so many different AI models, and it's a journey. And this is, as you can see, healthcare is pretty more complicated than what we think. And being a radiologist, I completely understand that AI is there to solve only narrow problems today. And there is a lot of opportunity in terms of how it can really augment. But today we are looking at very narrow problems. You would definitely, if you're interested, you should review how AI get evaluated. So there are certain important aspects like the area under curve, the sensitivity, the specificity, and so on and so forth. And there's one such research paper where we were evaluated in other AI companies, and that's available in Nature Scientific Report that could be linked. read, but also want to add a few more things, that AI is not only about detection. AI can also help in various other ways. It could be helping in dose reduction. It can also help in image, in enhancing the quality of the image. It can also help in extraction of certain information from the image, which could be radiomics. That's a completely different field. And it can also help in predicting mortality and morbidity. This is one such study which we did for COVID with a few hospitals in Mumbai and Pune. And we believe that something like this is going to be the future, where the clinical data married to imaging data can help us throughout important aspects in terms of predicting the hospital stay, the morbidity and mortality. And that's where the way the AI is moving ahead. Similarly, we had a paper where we have tried to see how tuberculosis and COVID can be detected in the same X-ray, and that was which I just discussed previously. When we launched two models in tandem, we can launch up to 19 models in tandem, but it's very important to take the discretion as to what is going to add value. Is it a public healthcare screening? It's in the ICU. Whether it's going to really impact, or and what's the capacity of the resources available? What kind of strength of laptop? What kind of X-ray machines are getting used? And that all goes into the decision making. So every AI model will go through this part of clinical research validation before it actually comes into clinical practice. So this is, as you can see, what we observed in tuberculosis, the same thing is observed with every AI model. If you look at point solutions, they will always match the expert, or at times even exceed expert, and help the expert in kind of augmenting the workflow. Pulmonary nodules also a very important area, because very high chances of nodules getting missed on X-ray chest, and that's where it reduces the stress of reporting, reduces the burnout, and adds to the radiologist report. Recently, we just published this in, and there are more than 25 such research they are available on the website, but you could, these are just a few key research which I wanted to show. And this is the recent research which is in MDPI, which talks about it not only can detect various pathologies, whether it's of the lungs or the pleura or the heart, but it also brings in a 21% reduction in the report turnaround time. So it augments the productivity of like close to 21%. And that's the value it comes in. So I think I've finished at 7:57. I just have two videos where we just not talk about the technology. We see how it actually gets integrated into the workflow, whether it's the machine or whether it's the packs. Because unless and until it does not come into the radiologist's workflow, radiologists are not going to get value out of it, or they will not feel the value out of it. So what I'm going to do is just walk you through these two videos quickly.
Yeah, Dr. Amit, there are a few interesting questions also in the chat box. So we'll like you to answer those. That would be really interesting.
Sure. Okay.
Welcome to Genki, Deep Tech.
So should I answer them first?
Dr. Amit, let's finish the videos first, and then we will take up the questions. I've written it, and we will take it one after the other.
Okay. Okay.
Sure. So I'll just quickly show one video for shortage of time, and probably we could.
Welcome to Genki, Deep Tech's AI-powered chest X-ray screening solution. Genki offers seamless integration with DR as well as CRX ray modalities. DICOM files can be directly pushed from the modality to the platform with a simple one-click option. Once the files are transferred, patient data will be auto-populated on the study list. The platform also has an option for uploading scans directly. Once a scan is uploaded, auto triage is done in less than a minute and pathologies are recommended. Instant results ensure that suspected patients can be educated on the spot and cases are not lost for follow-up. In case the scan is suspected to be normal, the result will display none. Here is a case with scan suspected to have TB and pneumonia and other pathologies as well. Users can also view the heat maps and outlines recommending the infected region and review the detailed analysis of all 10 pathologies with mention of confidence score. Outline and heat map can be disabled. Zoom in, zoom out, and pan view options are also available. Users also have an option to delete the study and filter the studies using various search options like patient name, pathology, patient ID, and date. Users can also see the real-time storage availability and ensure they take necessary steps on time.
Right. So I think that covers the video. a very quick video just to get an idea as to how it actually enters the machine or the workflow. I'm happy to take questions. So any particular question you would like me to look at basically, or
Dr. Amit, there are a few questions. I will just voice
Yeah.
those questions. The first one is regarding the anatomical part. Which
Yeah.
cardiac chamber is not seen in the PA view? That is
Pardon?
the few anatomical questions. Which
Okay.
cardiac chamber is not visible in the PA view? It is asked by Dr. Anita.
Okay. I think on the PA view, we can see the left, we see all the chambers from their profiles. We see the right atrium very well on the right side of the heart. The right ventricle probably is not something which is very clearly seen on the right side. It's seen on the left side because it grows, both of them enlarge on the left side. So the left as well as the right ventricle will be seen on the left side. We also see the left atrial appendage. We also see the pulmonary conus and the aortic arch. So that's what we've seen on the anterior posterior of the PA view. On if it's the lateral view, then basically we can see the left atrium and the left ventricle posteriorly and the right ventricle anteriorly. So if you want to see the chamber enlargement and you want to predict which is this likely chamber, that's how you have to see. If you see the apex is more kind of pointed, its left ventricle is more rounded, it is right ventricular, and if you're not able to make out whether it is rounded or pointed, it could be biventricular as well. And that's where 2D echo will come in and give you a much more better analysis. So I think, but cardiac is very interesting because you can even do the valve analysis and the valve calcification analysis using that. And I think Dr. Nidhi is there. She's the best person to talk about it, but that's a very quick overview.
But I really like the statement that you said that reading the chest X-ray is actually an art, because we see so many three-dimensional things in just a two-dimensional view that we really need to learn how to look at the chest X-ray and to read it.
Yeah.
There are a few more questions which are anatomical based. How do we proceed for any suspected retrocardiac issues?
Right. I think the way the protocols may change based on resource setting. Again, that's why the resource setting is very important. There will be institutions which could be a primary health center where access to even CT scan may be difficult, but an ultrasound machine may be easy. So if the lesion is posteriorly located, the next step is to do a lateral X-ray to see the localization, whether it's really retrocardiac or it is actually overlying the heart. If it's a retrocardiac and you can see it's very close to the rib cage, you can very easily put in a probe and see. Because if it's water density, it means it could be loculated effusion. If it is something solid, it can be seen, and you can even go ahead and do a biopsy. And you can also check a color flow to look for any vascularity in the lesion. Ideally, if the institution is much more advanced or tertiary care center, we directly go for a contrast enhanced CT or a plain CT first and then a contrast later, based on what exactly are other symptoms or clinical history and allergies and everything. But that could be the workflow based on the resource setting. So again, coming back, it ultimately boils down to the resource setting. We have cost-effective tools like ultrasound. We should make use of that. But if you're not able to, or if you already are much more advanced, you could directly jump to not even a lateral X-ray or ultrasound. You could probably do a contrast enhanced CT. That's how it works in tertiary care institutions. So both the options, but ultrasound is best because it can also do a biopsy on that.
Dr. Vinita, can you please take the next two questions? Dr. Vinita, you're muted. You have to unmute yourself.
Yeah, okay. Yeah, thank you. So I think the next question is, what is the basic difference between empyema and lung abscess?
Right. I think it's a parenchymal. Empyema could be in the pleural space, right? Empyema is what happens is that there could be thick loculated collection, typically seen in tuberculosis, so many different infectious conditions beyond tuberculosis. It creates these strands and fibrous web-like structures, very thick, very difficult to aspirate. You got a large gauge needle to aspirate that, and it can also result, if not treated, can also result in calcification in the pleural space. It just becomes like a rind-like thing with a thick wall of calcification if not treated. But lung abscesses in the lung parenchyma. Lung abscesses can be seen in immunosuppressed patients. It can also show fluid levels if it starts connecting with the any main bronchus, right, or the left main bronchus, and it will start cavitating and it will show fluid levels. And if you see fluid levels, probably this lesion or the abscess has started connecting with the bronchus. Otherwise, the difference is one is in the pleural space and the other is in the lung. So that's the most important basic or fundamental difference, but easily said that done. Many times we all know it becomes so large, even on CT, it becomes very confusing to tell whether it's a lung abscess or it's an empyema, because CT also sometimes does not add. the value because the lesion is too large, and we are really having challenges to say whether it's in the lung or it's in the pleural spaces, and we see that typically with large lesions. And it could also, if it's in the pleural space, if you tap it, it also may show fluid levels. It may show like hydropneumothorax kind of picture, and it's seen in tuberculosis and many other conditions, specifically the emphysema.
Okay, so we have one more question relating to similar findings. I think
Right.
how to differentiate image characteristics between cardiomegaly and pericardial effusion.
I think the way the pericardial effusion look is like a bag, like the way the apex is very narrow. The apex is what we call as the pedicle. Pedicle is at the superior mediastinum. That's where what we call as the vascular pedicle. It's very narrow, and below is more like a rounded structure. It's like a bag-like structure. One thing. Second important thing is heart becomes globular. It's called the globular heart. The third is you'll not be able to define these apices of the heart because fluid is now taken over. It has increased the density around it. So you can imagine the internal structure of the heart margins are not well seen. That's why it looks globular. So it's like a bag of coins or something like that. And that's most important thing. So the heart will be unusually largely enlarged if it's large effusion. The pedicle will be significantly narrow. The shape of the outlines of the heart and the structures will not be very well seen because it has been now taken over by the fluid. And that's how we basically differentiate pericardial effusion from chamber enlargement. If you,
Okay.
as you see more and more cases of pericardial effusion, you can very clearly distinct and say
Okay.
this is likely to be pericardial effusion. But Dr. Nidhi can add actually.
Yeah.
No, you're absolutely right. If the shape of the heart is maintained, and it is just the enlargement of the entire shape of the heart with the narrow pedicle, as you very well said, it's a pericardial effusion. If the chambers are enlarging, they will maintain the shape of the heart, and the various chamber enlargement will be seen beautifully. Dr. Vinita, are you taking the next questions, please?
No, I think you can go ahead with the next two questions.
Next questions, I will not go in detail with the next questions, but the summation of the next questions will remain around how AI is going to be validated. That is the summation of the next questions, that will the AI report will be considered as an authorized report, and how we will validate it. Like if we have released a report which has been generated by AI, if the patient is going to question, who is going to take the responsibility of that report? That is what is the summation of next two questions that have been asked, 2 or 3 questions.
Very happy to see this question, and I think that's where we come to the various different issues around AI, and this is a very important aspect. AI report cannot be released to patient unless it is validated by the radiologist. Please note that these tools are going to be used as an aid to augment radiology workflow. Number one, whether it is brain or it is prostate cancer imaging or maybe liver, or they all tools which are used to augment the radiology workflow. Number one. There are certain use cases which are emerging where AI reports could be directly used again by healthcare workers for certain conditions. Like tuberculosis is one interesting use case where it could be used directly by healthcare workers, but it will be always, it's very important that it needs to be audited by radiologists. And there could be use cases, for example, like breast imaging, where microcalcifications and a breast X-ray need to be imaged by 2 radiologists. It may happen that one of the radiologists could be the AI and one of the other will be an radiologist. So basically we know it's so difficult to get a mammography report out if we have 2 radiologists, and the timing and the inter-observer variability. If there is an AI model and that becomes a virtual assistant to the radiologist, the way AI is going to come is to be a virtual assistant to the radiologist or an expert. It's not directly going to come to the workflow with an automated report unless there are certain conditions which are typically automated. For example, coronary calcium artery scoring could be one such condition. If it's just about scoring, it could be coming out. But you all know that when we do coronary artery calcium scoring, you find so many different other pathologies. You find an enlarged heart, you find some calcification beyond the heart as well. You could find aortic calcification. You can also find lung nodules or pneumonia, patches of pneumonia. So that's where the role of radiologist will always be there. But the job of doing that complex task of actually doing that calculation will be left to the AI. So the technology will just help in quantifying and adding value. It may not, I don't see in the next few years that the AI report can be directly consumed by the patients or physicians without an overview by the radiologist. So adoption will have to happen with the radiologist. unless there are very certain use cases where it could be directly used by the governments and NGO, specifically if you're looking at disease elimination. Probably I hope.
Dr. Amit, this is a personal. This is a question from my end. That how many years we're expecting that we will be able to establish AI as a basic replacement? I'm not talking that it's going to replace the radiologist per se. It's only going to help us in becoming a better radiologist and save our time. But how many years we're able to kind of make AI as a standardized tool where one of the radiologists or the two radiologists can be replaced? What is the suspected time?
Yeah, I think the way I'm looking for certain use cases like mammography, use cases for breast cancer, where we are looking at microcalcification, that's where there could be potential. But for chest X-rays and other things, as you know, there are so many different chest pathologies which could be present. AI is doing an amazing job of separating normal from abnormal.
True.
That's so if you're looking at workflow management in a hospital which is doing 200 X-rays a day or 200 chest X-rays in a day, you can always start using AI right from day one. Means today the AI is so mature, it could start doing this job for you. At a single click, you could separate your normal from abnormal, and you can start reporting the abnormal first. You can also start reporting the pneumothorax first, or you can also start reporting anything which is much more critical as per the workflow that you have defined. So this is already there into the workflow. So this is happening today as we speak. But in terms of report generation, and a report which will be 100% validated, I think that's a long journey, because we all know it all depends upon the clinical information that comes in, and the clinical information is then used by as radiologists. We all use this information to generate our opinion on the report. So that's not it's going to help. But yes, for study report comparison, so if there are 2 X-rays or 3 X-rays belonging to the same patient taken at 3 different time point in the same day or after a few weeks, that job can be given to the radiologist. So progress monitoring will be more objective. So as you can see, it is getting more and objective in his workflow. It can start quantifying lesions in an objective way, progress monitoring in an objective way. And that's where radiologists, as radiologists, we know getting 3 X-rays or 6 X-rays into our workflow, dragging and dropping them, seeing the comparison, putting them in the same line in which the X-rays were done, and then writing a one report. It will take 5 minutes of our time. That job will be taken over by the AI. It will give you a comparative report, a much more objective report. So that's where it's going to come in. But it's not anyway likely to replace very soon. I don't see that happening, because there are a lot of regulatory things that come along with it. It's always going to be an assistant to experts everywhere.
I think we are running. Oh, yeah, we are running over time. I would really like to thank Dr. Nidhi and Dr. Amit. It was a very informative talk. And now I would like to invite our honorary advisor, Dr. Sushil Jain. He is also the medical superintendent of Apollo Hospital, Indore. Dr. Jain, over to you.
Thank you, Dr. Vinita. It was really interesting. And just one comment on that, replacing the radiologist, the threat or concern about radiologists being replaced. I think that is not a valid threat, because technology over the years in the past has been increasing and it has not created any unemployment. I think it should be taken as a skill upgradation. So I mean, 10 years back, nobody would probably have thought of using a smartphone, but now everybody is using. Even the eldest person in our family is using the smartphone very easily. So that concern should not be there, that the technology would replace the human intervention or it will replace the jobs. It would be just a skill upgradation of that particular person. So if you are keeping pace with the skill upgradation, I don't think there's any threat for the jobs or the radiologists, or for that matter, any of the jobs were being replaced by the technology. The other thing is that the technology usually enhances the capabilities of human beings. It's not replacing the capabilities, it enhances. So when you're doing something, I mean, if we look at accounting, it was so difficult in the past, but now with the computer, it's so easy. Same as with the robotic, the precision we have. So that's how the technology should be looked at. Anyway, so with that extra comment, I would like to thank our speaker, Dr. Amit, chairperson, Dr. Nidhi, and moderator, Dr. Vinita, for this very interesting topic, and Dr. Nankumar to be present here during the talk. I'd also like to thank all the participants. We crossed 105, which was apparent here, might be more than that. and also the technical and IT team who has supported this session. So thank you, and we look forward for many more such sessions. Thank you.
Thank you. A
Thank
pleasure.
you, Dr. Amit.
Thank
Yeah,
you.
thank
Have a good day.
you very much, everyone. And then with this, I think we end the session today.
Thank you. Take care.
Thank you.